Out of curiosity. Okay, yeah, I can start out. And hello, everyone. I'd like to officially kick off tonight's town hall called What Happens and When. It's a special session on aging at Kerry's Place, as you all know. And I am Lise Leroux. I am the chair of the Kerry's Place, co-chair of the Kerry's Place Family Advisory Committee. My sister Jackie has lived at Malamute in Scarborough for more than 30 years. That's my connection to all of this. I will ask you, and I'll remind you again in a bit, to turn off, to mute yourselves for the next little while until the Q&A. So if you see the little mic at the bottom of your screen, if you could please click on that so that we don't get sound from your houses, that would be great. So welcome everyone. I mean, this is exciting because anytime we can get together with people at Kerry's Place is a good time. And on behalf of the organizing committee who's put together tonight's town hall, I really just want to thank everyone here who's taken time to be part of it. It's so good that so many of us are doing that. Now, as we were just talking about in a little preamble, aging is one of those topics that snuck up on all of us, it seems. I know that the parents out there probably never thought that there'd be a day that they'd be discussing aging issues at Kerry's Place. We all think of our children and our siblings as just our children and siblings, and we don't really think about aging. And surprise, surprise, we're now talking about aging, and that means all of us too. Here we are. And aging, presents specific challenges and concerns for this community, for Kerry's Place as an organization, and for all of our supported people individually. And we at the Family Advisory Committee found it came up in conversation time and time again among among the 8 of us who are members of the Family Advisory Committee. So often that we thought it would be the topic for this town hall. And I'm really glad we've done that. Now, like the town hall we did last year on finance and estate issues, we know that this is one of those issues that keeps people up at night a little bit. Health, money, those things keep us all awake because for many of us, there's not a lot of places to find out answers. So I hope you'll ask questions tonight. I hope some of them get answered. And most of all, I hope this all helps you sleep a little bit sounder at the end of the day, knowing that people are really wrestling with a lot of the issues about aging at Kerry's Place. So we're so lucky to be joined, and I will share my screen now. Let's just stand by. Very, very lucky to be joined by a whole lot of people at Kerry's Place who will go through this. But before we start, I'd like to throw it to just hang on. I just should show you who else is speaking tonight. Here's a list of who our speakers are. All these folks are going to be speaking to you about aging at Kerry's Place. And I'd obviously start with our CEO and President, Susan van der Velde-Kook, who will kick us off with some words of introduction and a land acknowledgement.
Thanks so much, Lise, and thank you to the Family Advisory Committee, which maybe some of you don't know, but the Family Advisory Committee they just passed their 5-year anniversary. So this wonderful committee made up of parents from all of our regions. They represent you, all of you on this session tonight. And they've really worked very hard in choosing the topic of aging. And as Lise said, this comes up over and over again in the Family Advisory Committee. So I'm very happy to welcome all of you. And it's customary at Kerry's Place that whenever we have a board meeting or an education session or a town hall, that we have a land acknowledgement. And as you know, we have homes all over Ontario. So we occupy many of the lands where Indigenous communities used to live. And so I have chosen the land acknowledgement for Newmarket, which is our head office. So if you'll all pause for a moment of silence, I'm going to read the land acknowledgement and which comes from our Newmarket site. So we would like to begin by acknowledging the lands that we are on today and which Kerry's Place Autism Services operates as part of the treaty lands and territory of the Haudenosaunee, the Anishinaabe, the Mississaugas of the Credit First Nation, the Mississauga and Wendake Neonwenzio, that is covered by Treaty 13, 1805, and the Williams Treaty, 1923. We acknowledge that Indigenous communities and peoples have had their land stolen and been subjected to systemic oppression for centuries. We commit to actively working towards reconciliation by confronting our past and our present and taking action to support Indigenous peoples. Thank you.
Thanks, Sue. So before we get going, a little housekeeping. As I mentioned, keep your mics off unless you're recognized to ask a question. This is certainly not new housekeeping stuff, but just a reminder. There's 3 Q&A periods built into the program tonight. So hold your questions until then and raise your hand at that time, your Zoom hand. You can yell your question too if you can't figure out the Zoom hand. That's okay too. You can always type your question at any time in the chat, and a number of us will be reviewing the chat and we'll get to those questions. Don't be worried about that. And again, if you don't find that your question is being answered in chat, raise your hand or even yell it out during the Q&A. If you have a very specific question that's just relevant to you and your loved one, it might be best to ask it at the very end, at the very last Q&A, or have that conversation with relevant staff. As I mentioned, this session is being recorded, so if you don't want your image on the recording, keep your camera turned off. So I think that's about it for housekeeping. Just a little overview before we get going so you know what's coming. We are starting with some interesting research compiled by Joanne Huggins, member of our Family Advisory Committee, on how people with autism age, what the research is showing, how that may be different. There's similarities and differences with the general population. How Kerry's Place is responding to the aging folks in its care. How does a nurse practitioner fit in that? How does it work from primary care to preventative care to acute care? What happens with hospitalization? What happens when people become chronically ill? We'll break there because that'll be a lot of material for a Q&A. We expect that would be about 30 minutes in. Then we're going to talk briefly about advanced care, and that's sort of the next stage, preparing for end of life. I know that that's not a topic that people like to dwell on, but it is out there. And, what is advanced care planning? What does Kerry's Place do to prepare families and the individuals for that? There is a process, which is very interesting, and you'll learn about that. Then we'll be talking about the role of families, like what can you do in all of this? And we'll have a Q&A there. And then I think a really exciting part is about housing. How is Kerry's Place expanding and meeting the needs of this aging population? It's an interesting demographic. It's a demographic switch that really Canadian society is dealing with, but this organization is dealing with it very precise way. You'll see some examples of specialized homes and how, our other homes that may not be specialized, but, how they're being adapted to deal with this emerging demographic. So that's the overview. You'll hear from about 5 of our best staffers who will talk about all of this. So we look forward to it. Now I wanted to do a little Zoom survey, but Zoom didn't work on this particular Zoom. So if I could, and it's just going to be hard, I'm going to stop sharing. We had this sort of chat informally, but I'm going to ask people to raise their hands. and we'll try and track this. How many people here have loved ones at Kerry's place who are under 30? Let's start with that. Anybody here with under 30-year-olds? Probably not. You probably wouldn't have signed up for this, right? Okay. How about between 30 and 39? Anybody? Okay, one. And that's about it. Okay, between 40 and 49. This is not scientific, but even if you're not on camera, you can put up your hand too. 40, 49, we have a couple. And how about 50 to 59? Yeah, a lot more. Yeah, I'm seeing 5, 6, 7, 8, 9, and there's probably more who are not on camera. Anybody with loved one over 60 here? Okay. Yeah, one. Phyllis, hello. Nice to see you. Just Phyllis. I'm sure there's more than that. But thank you for that, guys. I'm going to go back to sharing the screen. There's a reason why I asked that question. Hang on, because the numbers are really rather stark. Of the 230 people living full-time at Kerry's place, nearly 1/3 are over the age of 55. It's a pretty amazing number. And this photo here is people I know really well. This is my sister on the right, and her housemates at Malamute in Toronto. And you can just see by that photo, this is the issue we're dealing with, right? We're dealing with people getting older. So we're learning about that. And as I mentioned earlier, Joanne Huggins, a member of our Family Advisory Committee, has been doing research about how folks with autism age. And I throw it over to Joanne with her research.
Good evening. My name is Joanne. I joined the Family Advisory Committee in April last year. My brother Jonathan has been supported by Kerry's Place for over 37 years. Overseeing the care of my brother has slowly been shifting from my parents to myself. And through ongoing education, I'm trying to better prepare to navigate and support my brother in older age and eventually end of life. I'm happy to be here with the families to share some important things I learned. So autism was first recognized in the 40s. The early groups of autistic children are now aging out. Compared to the general population's model of successful aging, findings in a 2024 study indicate that when it comes to aging, outcomes for autistics are generally poor. These are marked by increased medical conditions, higher risk of cognitive decline and mental health conditions, reduced physical activity and social participation, lower adaptive skills and quality of life. Next slide.
Okay. Because you haven't gone through the other ones? No? Okay, I'll go through.
Yeah.
Right.
People with autism age differently from the general population. Each individual with autism will age in a unique way. Aging begins at a younger age. Someone in their 50s may present with similarities in mind and body of someone who is much older who does not have autism. Those with higher autistic traits experience a faster pace of aging. Lifespans are unpredictable. Some improve, some stay the same, some lose skills. They have more physical health problems than the average person. For example, sleep disorders. In Canada, 24% of the general population suffers from sleep disorders versus 85 to 95% of autistic adults who suffer from sleep dysfunction. Autistics are more prone to co-occurring medical conditions, for example, autism plus ADHD, or anxiety, or depression, etc. Not only do these conditions present in a specific way, within these conditions, there are specific things that may occur with greater frequency of aging. For example, autism plus seizure disorder. Some may experience faster cognitive decline. Lifelong seizure meds cause side effects that increase with age. If seizures limit a person's physical activity when they are younger, this creates heart health risks as they get older. Frequent falls during seizures may cause fractures and seriously impact the person's mobility as he or she ages. Aging autistics have unique challenges. Behavior, communication, and pain present atypically. Autistics can behave in unusual and seemingly bizarre ways that may be misinterpreted. Conventional communication is often compromised. In the case of nonverbals, they will communicate their physical and mental distress through behaviors. There's a huge risk of making incorrect assumptions. Pain can often be missed as it shows up in uncommon ways. Experiences of pain and pain responses can include laughing, humming, removal of clothing, which could mask the seriousness of a medical condition. Nonspecific changes to vital signs, being less responsive, being more withdrawn. Pain can manifest in changes to food and drink consumption. Agitation and an increase in behaviors may be the only clues that they're in pain. For example, communications of distress, aggression to self and others and property, running away, could be misinterpreted and seen as problem behaviors. How does your loved one express pain? Are there subtle signs? It is the task of the doctor, support workers, clinical and family to determine whether these behaviors are the core features of autism or if there's something else going on at the same time, like potential medical and health causes that need to be identified. This is to avoid delayed and misdiagnoses and wrongly prescribing meds. Higher rates of multiple med use equate to high risk for adverse effects that impact their quality of life negatively as they age. There are lower rates of screening and early detection. Issues that could have been taken care in a doctor primary care setting result in more visits to the emerge. Misdiagnoses in emerge result in repeat visits. So here are some common medical conditions that autistics face as they age, as observed in doctors' offices and emerge departments throughout Ontario. I'm not going to go through everything, but just point out some highlights. For the brain, there is an increased risk for dementia. Ontario health providers report dementia being detected too late until the person is in crisis and options become limited. Genes play a role, as well as other factors increasing risk, including diabetes, depression, high blood pressure, cholesterol, poor sleep, social isolation, and absence of family has a big influence. For bones and joints, there's a higher prevalence of arthritis and osteoporosis. Again, the adverse effects of multiple meds advancing aging. For the tummy, GI-associated distress presents as sleep disturbance and other behavior problems, such as aggression and self-injury. For bowels and bladder, as the metabolism slows, constipation increases. Bowel obstruction is very common. For hearing, earwax buildup. Doctors see this one a lot. It can affect sensory, balance, mood, and cognition. For dental, impacted teeth cause pain, which can present as aggressive behavior and food refusal. For the lungs, they have more difficulty swallowing as they get older. Food, saliva, and vomit can get caught in the lungs and lead to higher aspiration rates. Aspiration pneumonia is very common. And for feet, the skin becomes drier. Callus buildups, cracked heels, sharp ingrown toenails, making it harder to clean and care for feet. This is also very common. This can affect sensory and can be painful, affect mobility, balance, and increase the risk of fall. So how do you figure out what's wrong? All behavior is communication. It is important to rule out health and medical causes first. Next, consider what is going on in their physical and social environment. For example, changes in their routine, noise levels, interactions with new and unfamiliar staff. Then consider what life events and changes may have given rise to this behavior change. For example, trauma, loss, or grief. Each step gives the opportunity to figure out the cause of the behaviors and to adapt care and support needs. Evidence supports that behavior interventions are more appropriate and effective measures. Psych meds should be the last resort. Differentiating the core features of autism while distinguishing the difference between healthy aging and illness associated with aging can be really challenging. What is your loved one's normal? Family knows their supported loved one's normal better than anyone. It is important to establish baselines, use monitoring tools, to work together through good coordinated healthcare from primary to preventative. This helps the doctors, social workers, clinical and family monitor various health aspects as our loved one gets older. To be proactive when there is a shift from normal baseline, to address expected age-related changes, as well as the risks for onset chronic conditions. This gives the precious opportunities for timely intervention, treatment options, and influencing effective outcomes. Thank you.
Thanks, Joanne. And by the way, everybody, Joanne's dad was the family doctor for many of our folk way back in the early days. This is a list of her resources that she used for compiling this. We'll obviously not expecting you to write this down, but we'll send it out to you in the email after this town hall, and it'll obviously be posted on the video as well. Thanks so much. Now, so given all of this, how is Kerry's Place responding to these very special needs of folks as they get older? Carmela Campanella-Borraccia is the VP of Clinical Services at Kerry's Place, and she joins us now. Carm.
Thanks, Lise. Hello, everybody. So Joanne shared some really great information about what we have to consider as we're supporting someone through their continuum of care. So our overall goal is to keep everybody as healthy as possible at all ages. And we also have to look at the specifics in regards to what preferences they have, what is going on around them in the environment. So Joanne touched upon that. So at Kerry's Place, what we look at is person-centered care approach, which aligns with Kerry's Place values, along with the values of the family. And we look at what's called a biopsychosocial model to identify those aspects when there's changes in mental health conditions or health conditions and what have you. At Kerry's Place, having the clinical umbrella within the supported living homes, we have our primary care of our nurse practitioner. We also have a really great working relationship with the families as well as the physicians. So part of that is looking at when there's changing needs of someone's health, whether it's because of the things that Joanne had mentioned earlier. There might be some medications that they've been on for a long time, which can affect their internal organs and so forth that we have to monitor. There might be other diagnoses that we have to consider and be very aware of. And when it comes to aging, there are other things that we have to consider. So things like sensory loss or, dementia, or if there's any other aspects such as cancer or epilepsy that we have to actually look at. So part of that is starting with that primary care, making sure we have that really good working relationship with the substitute decision makers, whether that's the parent or the siblings, as well as the physician. We also have that working relationship with our nurse practitioner. So Jennifer will speak a little bit more about what that looks like in upcoming slides. By maintaining this type of relationship, we can ensure those annual checkups and making sure that everything is just working fine for our individuals. But part of that piece as well is we also understand that as they're aging, there are other tests that we should be bringing the individuals to. Things like if I think it's over the age of 50 for women, they have to, there's the mammogram and so forth. So we have to make sure that we can bring our individuals to those appointments for those preventative measures. That way we're not, finding something out in the last minute and then becoming reactive to trying to support. So with those preventative measures, we can make sure that we can, better support our individuals. The other aspect of it is training staff on early detection. So again, making sure that they're understanding of when to bring individuals to appointments for certain tests as they age, making sure their eyesight is being tested, hearing, and so forth, those are the things to consider. Because as Joanne mentioned, we do have many individuals that are non-vocal, so they can't really tell us what they're feeling or what changes may be happening. So we really do rely on observing changes in behavior and so forth, and relying on the family members as well to let us know what changes they are observing so that we can better support the individual. Part of this aspect of training and staff on early detection is also that monitoring piece, so that when we have our individuals, say, for example, that have diabetes or blood pressure, that staff are well equipped to support monitoring the blood pressure, or monitoring the blood sugar levels and so forth. So those are the things that we look at ensuring are happening. So next slide, please.
Okay.
Okay. So we do recognize that needs may change. And again, we're always looking at the biopsychosocial model and making sure that the person's care is person-centered. So it's all about them, which means that what we might consider for one person may not be the same for another one. It's very individualized. When there are changes that do happen, whether it's acute or chronic illnesses, and Jennifer will speak a little bit more to this, that may require hospitalization, we want to make sure that the individual gets the best support. So we do have an in-house clinical team. We do have their nurse practitioner, works alongside with the frontline staff, the manager, the families, and so forth. The importance of having this in place is so that when the individual is hospitalized and, say, discharged, or even hospitalized for a few days, we're there to support, and also to make their transition back home much more successful, so that we have certain things in place. So for example, if someone had to be hospitalized due to, say they had surgery on their leg because they had an accident, as an example, and we needed a wheelchair for them back home or some mobility devices, we want to make sure that we're prepared for that before they go back home. So all those pieces are things that we consider. And our nurse practitioner, again, is part of that circle of care to ensure that information is being transferred, that that staff are prepared to support the individual on their return home. And again, that the family is informed and they're able to provide their feedback and input onto how to make things successful. As I said, the care is sorry. It's okay. So again, we're doing everything to ensure that everybody that we support have the option to stay in their home. As I mentioned, it's very individualized what we look at. And, I do say the biopsychosocial model, that is an aspect we look at. Our person-centered framework is also on our website if you're interested in seeing what we look at when we're looking at individualized care. Looking at the needs of whether or not the individual needs to be hospitalized and so forth. And we always strive to have the option to have the person stay at their home. In some situations, though, we, again, will have the conversation with the substitute decision maker, whether that's a family member, a parent, a sibling, because there have been times where we might have to look for long-term care. It's definitely a last resort for us. If there was a hospice situation, we would look at that. But there are some times where the family member would prefer to have their loved one transferred to that type of environment to get the care that they need. But we do strive to make sure that the individual is, comfortable, that their quality of life is improved, and this is what we strive to do. So now I'll pass it to Jennifer so she can go into a little bit more about what her role is as a nurse practitioner at Kerry's Place.
Hi, everyone. I'm Jennifer. I am a nurse practitioner at Kerry's Place. I've been here for about a year and a half, but I was here previously when the former nurse practitioner, Betty, was on maternity leave. So I'm not new to Kerry's Place. I have been a nurse for a number of years and worked in lots of different settings, both in the community and the hospital, and as a nursing educator as well. And just so you know what nurse practitioners can do or who nurse practitioners are, I sometimes say that I can do things similar to what a family doctor can do. So that means assessments, diagnosing people with illnesses and disease processes, ordering tests like blood work or x-rays, giving vaccines like flu shots, doing wound care, and of course, writing referrals if people need to see a specialist like a dermatologist, for example. So that's sort of what nurse practitioners can do. I'll tell you a little bit more about what I'm doing more specifically here at Kerry's Place. So I do have a caseload of individuals who are what I'm going to call medically complex, meaning that they have more challenging medical issues or health issues, as well as a handful of folks who are over 50, who I'm seeing more for that sort of preventative side of things, just trying to ensure their blood pressure is okay and that they're aware of screening tests that are recommended and things like that. Of course, my end goal is always to keep people healthy and well and minimize their ER visits or hospital visits because nobody wants to go to the hospital unless they have to. What I do, particularly for the folks on my caseload, is regular check-ins and assessments, and that involves me talking to the person themselves, as well as the staff, to see if there are any concerns regarding health that has come up lately. I will do a brief assessment depending on the person's tolerance for that, but I try and check people's blood pressure. I try and do a quick listen to lungs and hearts. Sometimes I might ask about weight, if weight has been an issue for an individual, really depending on what that individual can tolerate or not, and sort of what's come up, if anything, for that individual. Of course, a big part of it is talking to staff about preventative care. So, as Carm said, things like checking people's blood pressure, because we know that can be an issue for older folks. Screening tests like colon cancer is a big one I've been talking to people about lately, because most of us can do a fairly non-invasive screening for colon cancer. You don't even have to leave your home. So it's relatively quick and painless, I'm going to say, and a good screening test just to check and see. So I've been talking to staff about that. And of course, I refer folks to specialists, healthcare professionals. As I said, it can be a medical specialist like a dermatologist, an endocrinologist, a cardiologist, depending on what the need is. I've also done lots of referrals to what used to be CCAC, was then the LIN, and now is Ontario Health at Home, which is basically home care for things like physiotherapy, occupational therapy, and that kind of thing for supported folks that might need those services. So I'll just step into the realm of hospitalizations and what happens if a supported person gets hospitalized. So I sort of say that I become the care coordinator, if you will, and try and connect the dots between the hospital and Kerry's Place to make sure everybody's on the same page. And I try to be proactive and as much as I can start thinking about that person's discharge from the moment they're admitted so that we know, if things have changed, if they might need a piece of equipment when they get home. How are we going to be able to support them when they return home? What things do we need to put in place? And just to give you an example, if somebody's fallen and broken a bone like a hip or a leg, that can change the picture of what sort of supports they might need at home significantly. So trying to be proactive and put those things in place before the 11th hour and they're getting discharged. And for example, we don't have a wheelchair for them at home, or we don't have a ramp for them to get into the home, or a seat for them to use in the shower. So just trying to ensure those things are in place and that we're having those conversations before they're discharged home and we're scrambling to try and get things in place. And so sometimes folks get diagnosed with an illness or disease process that becomes chronic. And some things that are pretty common are diabetes and high blood pressure. So of course, we do everything we can to make sure that our supported folks can stay at home and are looked after by our staff and myself. And often that just requires some education for staff around, how to check somebody's blood pressure, how to check somebody's blood sugar, what to do if their blood pressure is really high or really low. Sometimes it involves some external supports, as I said, like home care, maybe coming in to do physiotherapy with somebody who's broken a bone and fallen, as I said, and broken a leg or a hip. Of course, the family is important and the wants and wishes of the family are very important. And I'm happy to speak to family members if and when that comes up. And we always consider what their wants for their loved one are. And as Carm said, long-term care is really a last resort, and only if we've sort of exhausted our options for support for a person in our care, and they've sort of gone beyond the scope of what we can provide, and then we might consider that as an option. But of course, that's again in conversation with families. And I'm just going to hand it back to Carm to speak about the role of the family.
Thank you, Jennifer. So the role of the family in the circle of care is very, very important. Families play a crucial role in supporting the individual's decisions. They also play a crucial role in identifying, what the person likes, what their loved one enjoys to do. Things like, how Joanne had mentioned earlier on in the presentation, that there might be certain, if the individual can't verbally express that they're in pain, there might be certain sounds that the family knows a lot about, where it's happy sounds or maybe painful sounds. So those are the things that, we want to have those conversations with families about, and ongoing conversations. We don't want to just have a conversation with the family when things are, going wrong or so forth. We want to have regular conversations with families so that we can monitor the changing needs of your loved one. And again, this encourages open conversations. We understand what healthcare preferences are. So we do have an in-house nurse practitioner, as Jennifer has just explained, but there are some family members that are, they primarily just want to have their physician only taking care of their loved one. And as much as they appreciate that there is a nurse practitioner, they just are more comfortable with that, and that's okay. And that's something that is important for frontline staff, for us at Kerry's Place to understand. Again, having that role of the family helps reduce anxiety and stress in critical situations. Again, we want to be as preventative as possible, as proactive as possible, so we can have those regular conversations. So when we do have to have a difficult one, such as, say something along the lines of the advanced care plan that Erin will speak to about a little bit later, there's less anxiety and stress during those types of conversations, and we can have more of that dialogue to help support the individual. And again, we facilitate the discussions to ensure the care aligns with personal values. So not only does the person-centered framework that we use align with our Kerry's Place values that are located on our website, we also ensure that they align with the family values and what their beliefs are, and how they'd like to, for them to provide feedback on how we can further support their loved one.
All right, and
Thanks,
this
Lisa.
brings back to me and about families, because obviously this is something that actually, Carm, you can deal with it too. I'll start and you can pick up. But
Yeah.
we talk about this a lot at the Family Advisory Committee, the role of the Individual Support Plan, the ISP. That's an expression you may hear, ISP, and you may not all know what it means, but that's that annual discussion that you and the frontline staff should be having. And it's a great time to talk about the stuff we're talking about here tonight, right? Is there a need for mobility needs? Is there, have either the family or staff noticed a change in mental health? Is there a need for more social activity? Is there, and I know somebody's asked this in chat, and we'll get to it in a minute, do we need to, do something in the home for accessibility? Do we need, more devices for self-care? Those are all the questions that need to be discussed in that ISP.
Yeah, and again, to Lisa's point, it's very important that they are discussed during that annual meeting, but you can have these discussions at any time. Because you might notice something changing, and the ISP meeting is not for another 6 months. Please, just, we're encouraging that open dialogue so we can better support your loved one when there's changing needs.
All right. So this is your time to ask questions. There's already several questions in the chat. And I will stop sharing this for a minute. A couple of questions right off the bat. One from Rebecca, and I don't know, I have to say, I don't know what this means. Is CRP used as a measure to determine if the drugs elevate inflammation? Can anybody answer that? Because
Ye- So, I mean, Jennifer, if now she's come off the screen, but I'm pretty sure that's a marker for a blood test, if I'm not mistaken. And that would be something that the physician would look at. So if our individuals do have, any type of medication that could elevate inflammation, things like that, we do have a partnership with a pharmacy that also looks at those pieces, and the physician would inform us as well. Does that answer your question? Jennifer, I don't know if you want to add anything else to that, but.
Yeah, thanks, Carm. Certainly I would say that's something the physician could order, certainly, if there's a concern about inflammation. And I'm thinking about specifically with folks that have things like rheumatoid arthritis or lupus, things that we know will cause inflammation. Absolutely. I would say it's probably not something that's routinely ordered, but if that's a concern for your loved one, please let myself or your loved one's primary care provider, their family doctor, their nurse practitioner know, and we can certainly discuss that.
Can I just add something to that question on the CRP?
Mm-hmm. Yeah, go ahead.
That is a marker. It's a very generalized, non-specific marker, and it can go up for numerous reasons, not related. It causes too many types of inflammation, so it's not a good test to be zoning in on any particular inflammatory process, and it could go up, elevate itself for a number of reasons that are not related to inflammation, directly related to inflammation. So it should not be really used as a marker for any medication or for any other form, because it cannot be, it does not point to any specific form of inflammation. So it's a very generic type of inflammatory marker. So although it is done, it really doesn't, because initially it was thought that elevated CRP was associated with a lot of cardiovascular and all of stuff, but this is associated with any form of inflammation in the body, some of some concern, but most are not of concern. So I wouldn't depend too much on an elevated CRP. It's all over the map, for any particular individual. So,
Okay, thanks. Oh, sorry.
yeah. So just, I don't want to make it sound like it is a specific test for any specific condition. It's not.
Right.
Okay.
Okay, well, that's Joanne's dad, Dr. Huggins. Thank you, Dr. Huggins, who is, in case people don't know, Dr. Huggins, he's a dad of one of our
Yeah.
residents and is a family doctor. So just in case people didn't know what the intervention was. Eddie asks a question. How is Jennifer, the nurse, made aware of the resident who's been hospitalized or returning home from hospital to the group home and requires special care? Maybe Jennifer, you can talk to how you get told about somebody. Is Jennifer there?
Yeah, sorry, just unmuting myself.
Yeah.
So for the most part, the managers will let me know when somebody in one of their homes has been hospitalized. The managers are good about contacting me and letting me know. The other thing that sometimes happens is incident reports or serious occurrence reports get filed, and then that sort of notifies all of the leadership team that something has happened, and it trickles down that way sometimes as well.
Okay.
If I can
great.
just add to that, Lise, this is Sue Koch, and if anybody's hospitalized, it gets to the CEO. It's very serious. We consider it very serious, and we keep tabs on it. I will, if a person is hospitalized and they're very, very critical, I will let the board know. So we consider hospitalization very, very serious.
Mhm. All right. Dick and Jean Winters asked, is there a plan to make the houses wheelchair accessible? I mentioned we will get to that in about 10 minutes. Are there any other questions that are not in the chat? Eddie asks, he continues, who informs the nurse practitioner, and would the families be informed that the CEO has been notified? Like who tells the nurse practitioner? I guess the frontline staff would be the ones,
I
right?
can answer that, Lise.
Yeah.
So yes, our frontline staff would notify the manager. There's a bit of chain of communication there where the management team would notify the director would notify myself, and then I would notify Sue, and she would be making that determination, of course, if the individual is deemed to be in critical condition or isn't any issues that are serious in nature, the board would be notified as well. In terms of the family being notified, our obligations as part of the incident reporting and SOR mechanism is to ensure that the family is notified, and any individuals that would be providing support to that individual, whether that be the frontline staff that are not on shift, would also receive some sort of notification.
All right. Anybody have any questions about the material we've covered so far? Okay. So we will.
Lise, I think there's another question
Oh,
there.
is there? Okay. Yeah.
Mhm.
Go ahead.
So I think the question reads, who do I talk to if I have specific concerns about my sister's medical care? So your first point of contact generally, and this is specific to both supported living and community, your first point of contact would be the manager. If there are any concerns or challenges that may arise from that communication, you can escalate that to the director and then further to myself as the VP.
Hi, can I ask you a question? I don't know how
Yeah.
to do it on the chat box.
Okay, go ahead, Maria.
I'm just curious because my son is considered to be his own SDM, and I find it very difficult to have I don't know what to call them. I guess communication, updating communication if he's gone to some doctors or appointments that I'm not necessarily aware of. I'm not told about it at times, and I also don't know what the results are, all because he is considered to be his own SDM. I appreciate that he is that, and I want him to remain his own SDM as long as possible. I think it's more dignified for him to remain his own SDM. However, I find that it doesn't necessarily assist, and I don't know how to go about getting informed if they're their own SDM. Is there a means of communicating what's going on?
Mm-hmm.
Who would like to handle that? Osman or Carm or Jennifer?
I can take a stab at it. So I'm not really aware of that specific situation, Marie, but what I can offer you is an opportunity to discuss your concerns with myself. We do here at Kerry's Place try to strike a balance between the capacity of those individuals and respect their desires, their choices. And I think there's a mechanism in place that we could support your family with, perhaps bridging that communication with your loved one and to see from your perspective exactly why you want to know some of these kind of notifications and how you're in a position to support them. So I think there's some further conversations that can happen, and I would ask you to reach out to me directly.
I appreciate that. Thanks very much, husband. Thank you.
All right, any other questions? Okay, I'm going to move on, and if something occurs to you, there'll be another Q&A and a third Q&A. So there's lots of time, and there's always the chat. So I'm going to bring up the screen again, and move on to Aram Husseini, who's our quality control officer, but also in this case, the person who handles the advanced care planning program at Kerry's Place. Aram?
Yeah, hi everyone. Good evening. So I'll be speaking to you about advanced care planning, and I was just looking around the Zoom room, and I think I recognize a lot of people's names and last names, especially for the people I've met with. So if you haven't met me, I am the person that you speak to about advanced care planning, it's a thoughtful and ongoing process where individuals can document their healthcare preferences in case they become unable to make decisions during a medical emergency or end of life. At its core, it ensures that a person's values, beliefs, and choices are known and respected. These conversations often involve the individual, their family, and sometimes support staff, creating a shared understanding of what matters most. The importance of this is that it brings peace of mind, not just to the individuals, but also to their loved ones and care teams. It helps guide healthcare providers to make decisions that truly align with the person's wishes. At Kerry's Place, we're committed to supporting individuals in creating meaningful advanced care plans. We use a structured, person-centered approach led by the Quality Outcomes Coordinator, which in this case is me, to ensure planning is tailored to each person's needs and comfort. Now, these conversations can take many forms. They might be a formal meeting that include the entire support circle, or they might just be an informal chat between a manager or a family member. Because we prioritize a person-centered model of care, these discussions are already happening naturally and regularly as part of how we support individuals who can create an advanced care plan. So generally, anyone over the age of 50 in supported living, anyone with a medical or life-limiting condition, but also anyone who simply wants to be proactive about their future care, we have the capacity to create an advanced care plan for them. Our process right now is that when a person supported residentially turns the age of 50, I will send an email to the manager with an information brochure attached. And then they will then share that with the support circle, asking if an advanced care plan is something of interest of them, letting them know what that meeting would entitle. Now, what can be included in an advanced care plan is a question we get a lot, and really it could be anything that's meaningful to the individual. For example, some families have already chosen burial plots and want that information documented, while others have cultural specific or religious preferences they want noted. We can also include personal touches. So we have one person supported who has a lifelong collection of memorabilia and things that they cherish. So in the document, we note that, having these items nearby them, if they're ever moved to a hospital or a hospice situation, would bring them comfort and peace. So that's something we want to document for all care teams and people around them to kind of know. I've even had one family who wrote a eulogy already and submitted that to kind of be documented, and also submitted a newspaper insert to be kept on file for future obituaries in their local paper because they've been in that area for a very long time and have deep connections. So these are the kind of details that really show how individualized these plans are. It can be anything or everything that brings peace of mind and reflects the person's values that can be included. Now, it's important to understand that an advanced care plan is voluntary. It's not written in stone, and it doesn't need to be followed as a legal document. It's simply meant to guide decisions during times when the individual can't speak for themselves or if a family member or SDM is unavailable. Anything in the document can be changed or updated at any time. At Kerry's Place, we always ensure that each person maintains their right to choose and to make their own decisions, regardless of whether or not they have an advanced care plan in place.
All right.
Substitute decision makers, so also known as SDMs. You'll see that acronym used a lot at Kerry's Place, and this is someone trusted to speak on behalf of the individual if they're no longer able to make healthcare decisions themselves. So typically, this is a parent or a close family member. At Kerry's Place, we work closely with the person and their supported team to identify who this decision maker should be. The SDM's responsibilities are significant. They're heavily relied upon to truly understand the individual's values and wishes. They work collaboratively with healthcare providers and to ensure that any decisions made reflect what the person would want, always upholding their dignity and best interests. Even when an SDM is appointed, it's important to remember that the individual still has the right to make decisions for themselves as long as they're able to. The role of the SDM comes into play when a person can't speak for themselves, and the advanced care plan serves as a valuable guide in those moments.
All right. Thank you. Thank you so much, Aram. That was really useful. We already have a question. Kimberly, would you like to ask it verbally, or do you want me just to read it? I'll just read it. My daughter, who is
Sorry, I have to
oh,
unmute
you go
myself.
ahead. Go
Yeah.
ahead.
So my daughter Jessica, she's at 3 Watson in Brampton. She is nonverbal, and just everything that you were talking about is a big concern for our family, because being nonverbal, she's not able to express to us what her wishes would be. So is 32 too young? Should we start a plan now? What's the best approach?
Yeah, I can answer that. So like I said, it's not a written in stone document. It's a guide, so we can start at any time. So we definitely have lots of people in their 30s that have already created one. So we can start that conversation. We can have my information shared and you can reach out.
Hello. My name is Lynette.
Yeah, go ahead, Lynette.
Yes, my son is 53 and he definitely cannot speak. He doesn't understand anything. So in a situation like that, he wouldn't able to say, well, this is what I would like to be done when the time comes for me and what have you. So I am the one who would have to make that decision, or his siblings, because he cannot choose or say anything for himself. So I guess that will be fine on my part for me to do it, like the substitute person to do it for him.
Yeah, naturally, that is what happens for a lot of people that we support that can't kind of speak for themselves. We have substitute decision makers, family members, people who have cared for them for a long period of time and know them well, all fall in that category.
Okay, thank you.
No problem.
Are there any other questions for Aram before we move on? It's interesting. So Aram, you've seen a lot of the folks on this town hall. Is it safe to say that a solid number of people have already started this process? Would you say?
I think there's still a lot more that we can do. It kind of really, yeah. So we've done quite a few, but I think there's definitely that reminder that we have this service available and trying to get everyone to kind of start that conversation. It can be as little or as big of a document as you want. So if it's just, yep, this is where we'd like to be buried. That's it. That's all. That's on the document. That's okay. Or it can be a little more extensive. So I'd love to meet with more people and kind of start that conversation, just document some things.
And how do I see that your question, Sandra, and we'll get to that in a minute. But if somebody, say tonight, decides I want to start this, do they contact you directly, or do they go through their manager? What is the process?
You can contact me. Maybe we can share my email address. The brochure has my email address on it that I usually share with the managers, and that's usually how we start that conversation. I can share my email at the end here for everyone to note.
Put it in the chat, maybe even.
Yeah. And if you kind of forget, just reach out to your manager. They all know about me talking about advanced care plan, so they should be able to connect you with me. That's
great. Now, Sandra's asking a hard question, but what if somebody dies at Kerry's place? Who would like to handle that? It has happened, so.
I can take that, please. So yes, it does happen. And where possible, we try to plan for these things through some of the mechanisms that were presented earlier today, like the advanced care plan. And for those individuals where that did not occur, we do reach out to their immediate family members and next of kin to ensure that we capture as much as their wishes that we possibly can, whether that be specific burial requirements, specific religious requirements, or anything that the family would like to see, and that incorporated also with things that we know the individual would enjoy. We try to collaborate the families to make that come to fruition.
Okay. I think we'll move on. And since you're speaking, Osmond, you are next.
Okay.
Osmond Gell, as you probably all know, here is our VP of supported living. And he's going to talk to us about how the housing is changing and adapting to accommodate our aging demographic. So over to you, Osmond.
Thank you, Liz. So good evening, families. Again, my name is Osmond Gell, and I am the Vice President of Supported Living with Kerry's Place. And I've had the pleasure looking around the room of meeting many of you in the past, and it's lovely to virtually host you all here this evening. As Lise mentioned, I'll be providing an update on our housing strategy, and I thought a good place to start would be our humble beginnings back in 1974, where you see pictured before you the original farmhouse, where in the small farming community in Clarksburg, Ontario, a group of families rallied around the O'Neill family specifically when they chose to courageously and at the time quite innovatively open their doors to support a handful of teenagers living with ASD. Their vision at the time was to challenge the status quo and offer an alternative to existing supports that were available at the time. And they wanted to ensure that their loved ones were full and equal members of communities and also received the dedicated support that they needed to reach their full potential. Next slide. Fast forward to 2025, and supported living makes up roughly about 80% of our operations here at Kerry's Place. We operate 58 group homes across Southern Ontario, supporting 230 unique individuals in our treatment homes, traditional group homes, where they receive 24-hour care. We also support an additional 40 individuals in what is called our semi-independent program, or SIL program, where we offer supports at less than 24 hours based on the needs of those individuals. Now, over the 50 years of which Kerry's Place has been operating, and I just wanted to put that in there that Kerry's Place turned 50 last year, we know and we've noticed for quite some time that our supported individuals are living longer. And the research provided earlier today from my colleague Joanne Huggins kind of highlighted that, the individuals are living longer and their needs are changing, requiring Kerry's Place to adapt and develop specialized housing models to support these individuals as they continue to age. So our housing strategy aims to address this gap while focusing first on expansion and developing specialized housing models that focus on accessibility, physical environment, and we hope to expand our capacity overall as an organization by about 68 individuals, which would represent roughly a 25% increase from the levels of the numbers of the individuals we support today. A key part of our housing strategy focuses on renewing our existing housing stock. And that can mean a variety of different things. But for me, it means adapting physical spaces where possible to better meet the evolving needs of the individuals we support. And the overall goal of our housing strategy, from the renewal perspective, is to promote well-being and enable the individuals to age in place with comfort and dignity. So I thought it'd be a good opportunity now, and I know some of the stats have been shared earlier, but indulge me here where I can provide you a quick snapshot of our current demographics. As you can see on the chart to your left, roughly about 60% of our individuals currently in our care are over the age of 40. Another 29%, or roughly a third, has been mentioned a few times today, are over the age of 55. The middle chart that you see there highlights the varying medical needs that many of our individuals that are in our care are living with. And you can see roughly about 41% of our individuals are living with either a medical concern or a physical concern. So mental health concern. And last but not least, on the chart to the right, roughly 11% of the individuals that are currently in our care today live with mobility challenges. And we anticipate that number to increase by an additional 16% over the next 5 years. Next. So based on this data, one can infer that over the next 5 to 10 years, the needs of our individuals, particularly in terms of accessibility and age-related considerations, are going to continue to evolve. And as I've mentioned, Kerry's Place is adapting our housing models to respond to these changing needs and ensure these individuals can continue to live safely and comfortably in familiar environments. So as I've shown in those statistics, this shift is going to bring a range of evolving needs, some of which may be compounded by their existing diagnosis of autism. You can use the washroom, it's cool. We all recognize that for many of our individuals, long-term care is not an option, nor is it an appropriate or effective solution many of the time. And in response to this, we are working towards, again, implementing housing models that prioritize accessibility and those physical modifications. And over the next few slides, I would like to take the opportunity to highlight 3 examples over the last few years where Kerry's Place has adapted either an existing home or has procured a newer home to better meet the changing needs of our individuals in our care. So the first example that I'll provide is of our Harmony home in Belleville in our Hastings region. Back in 2021, we made the conscious decision to consolidate 3 of our smaller homes that at the time were not conducive to the needs of the individuals residing there for a variety of different reasons. The hallways were narrow, and many of the homes had multiple levels, necessitating the use of stairs. So we took the 3 homes and we moved those individuals into the home that you saw pictured briefly in front of you there. Now, it may not look like a big home. However, I will share that there are about 10 residents that currently reside there. And to support the needs of our aging population in Hastings, we were able to dedicate an entire floor of this home to be fully accessible for those individuals. And some of the features that we were able to adapt in this space included wider doorways, hallways, larger bathrooms, and other accessible features such as automatic doors. On the lower floor of Harmony, we housed 6 of our individuals there where their staff would be able to provide backup to the individuals that were upstairs in the event of any medical emergencies or if there was any need of support for those individuals that are residing on our aging in place floor. And lastly, one of the major benefits of moving to Harmony was that the former homes were located in much more rural settings. And with this move to Harmony, we were able to move the individuals closer to the city of Belleville, providing much quicker access to not only medical facilities, but hospitals and even social activities for our individuals to take part in. I will provide another example of a project that we recently completed in our Orangeville catchment area. So very similar, we were able to take an existing home in this sense, and we commissioned the support of a design firm named Gensler to provide us with the tools necessary to implement a bit of kit of parts is what they refer to it as, but essentially it's a blueprint that could be adapted to physical homes. Maybe not all physical homes, but many of the homes that we currently have here at Kerry's Place. And we were able to adapt that specific location on Leader Drive to allow for aging in place. We were able to implement universal designs, including wider doorways, lower threshold entries, the walkway you see pictured in front of you there. And I also want to add that Leader actually houses many of our individuals that have been residing with Kerry's Place for over 30 to 40 years. And some of the original members of Kerry's Place also resided at our Leader Drive location. The last example that I wanted to provide was on a new project that we are currently working on, which is La Park Road. So when we did a review of some of the homes that we had within Kerry's Place, it became apparent that some of the homes that we had weren't, I wouldn't say worthy, but definitely required extensive work. And some of them even required demolition. So as such, we have identified one of our homes in the Caledon area, located on McLaughlin Road, as in need of demolition. The current residents also living at that home required very complex and specialized medical supports that included, for example, daily nursing visits to this home. And the current home, as it's laid out now on McLaughlin Road, was not conducive to continue to provide this support due to the physical layout. So we recently purchased a home in Brampton that was pictured there briefly that will serve as the future home of the residents currently living at McLaughlin. And our aim with this new home is to ensure that there are accessible features in there and that this home is physically adapted to better support the medical needs of the individuals that are going to be residing there. And as for the existing property at McLaughlin, we are going to be working with our ministry partners to determine what the next steps of that home is going to be. So as such, one slide back, please.
Yeah, sorry.
Yeah, no. As such, Kerry's Place is going to continue to actively assess our housing stock to identify not only necessary renovations, but ultimately any homes that could be adapted to support aging in place. And over the last few years, we have commissioned various studies, one of which I'm going to kind of share with you here today, which is called a BCI, or a Building Condition Index. And we commissioned a third party to support with an evaluation of all of our homes to determine the structural integrity, any homes that could be better suited for accessibility features, the overall functionality of the home and the space planning, while also, more importantly for me, providing a timeline of anticipated repairs over the next 5 to 10 years. So this highlights our extensive efforts here at Kerry's Place to not only dedicate or make sure that accessibility needs are prime in our minds, but also prioritizing safety enhancements and continuing to modernize our homes to align with the evolving care needs of the individuals that reside with us today and will hopefully reside with us for the rest of their lives. I will now pass the floor over to Lise, who will guide us through the next portion.
Thanks so much, Osmond. I know we have a few questions, but I just want to wrap here but on a key topic before we go to those questions. And that is the value of communication in all of this. Doing a town hall like this is great, but it doesn't substitute for the family to develop a relationship with frontline staff or the house manager. We heard from Carm, don't wait until the ISP or other formal processes. All the issues and some of the issues that are in the chat need to be discussed first with the primary liaison or the house manager. And if unresolved, bring them to go higher, go to the regional director, or if still unresolved, bring the problem to Osman Gal. If you feel that the medical needs or some other problem associated with aging or another problem just isn't being addressed. And, there's a complaint process if you feel you need that. That's on the Kerry's Place website. But we on the Family Advisory Committee cannot stress enough the value of ongoing communication between folks, between family members and staff. In fact, I mentioned at the very, very beginning that the Family Advisory Committee, one of its main achievements has been writing a charter of commitments. That's a document that outlines what's expected between staff and family members. And among the things it says is there needs to be this active collaborative relationship between family members and staff, and that there has to be open, honest, and constructive dialogue. You can read the whole Charter of Commitments, which is this document that applies to family members and staff and has been approved by the board of directors. And it's online on the website. So it's something to keep in mind. I know we have, before we get to the questions that are in the chat, a couple of notes, as it's 8:15 now. We really urge you to do a few things as family members. If you've enjoyed this town hall and you are appreciative of Kerry's Place work, really, we urge you to find ways to get involved. And by talking to your local politicians is one great way to get involved. If you see them this summer on the barbecue circuit, your MPs and your MPPs generally make themselves more available in the summer than any other time. Please talk up Kerry's Place and remind them that funding has not been great. The funding for developmental services overall has flatlined in Ontario for the past 30 years. And raise this concern with them. Consider joining the Family Advisory Committee. We're always looking for people. We're the people that brought you this webinar. And before we go to final questions, I really want to offer huge thanks to Phyllis Deisenhouse, Diane Gadji, and Joanne Huggins, who you heard from. These are the folks that were on the planning committee and brought these issues to the place where we wanted to make it into a town hall. And of course, from our presenters that you heard from tonight, Carm, Jennifer, Aram, and Osman, people spend a lot of time putting this together. So thank you to all of you. And before we go to thoughts about future town halls, let's go to some of the questions. And I'll just go back. Aram put her email in the chat, which is great. Catherine just needs some reassurance. Am I to talk to the manager if I feel the doctor assigned to my son isn't too aware of my son's ongoing health problems unless they become a serious problem? How would I access more help? He's 40 years old and does self-injury, such as hitting and face slapping, etc. Catherine, I don't know if you want to speak to your own question before we throw it to, I guess in this case, Carm would probably be the best person to answer it, but I'm not sure.
Yeah, I'm not sure if Catherine wants to add anything, but absolutely, you would speak to your manager. Oh, sorry. Oh, I thought I heard her. Yes, you would speak to your manager and you would have the clinical team involved, which also could include Jennifer, depending on what the situation is. So yes, I would encourage you to have a conversation with the manager and have the clinical team involved.
Catherine, is that enough, or would you like to, does that do it for you? Okay, I'll move on. Carol Ann asks, when we have so many people in one home, how do we prevent the care from becoming more like an institution?
I can respond to that one.
Yeah, go ahead, Osmond.
Yeah, so here at Kerry's Place, generally speaking, we do have homes that house up to 10 individuals, such as our treatment sites and some of the homes that we do have in Harmony, as the example that I provided today. Ideally, we try to stick within that 4 to 6 range, but we have made a commitment to not go beyond 10.
All right. Is it Haggett or Hadjit? I am so sorry if I'm butchering your name. What are the anticipated trends and outcomes for housing solutions for young adults between the ages of 25 and 35 in the coming years? Osmond,
I can respond to that one. Yep. So just generally speaking here, there is a target that we do have as part of our housing strategy for some of those individuals that are within that age range of up to 18 years old, up to about 35. And dependent on their needs, we are looking to implement a variety of different housing models, whether it's medically complex, specialized housing model for a specific cause, or if it's generalized group living, or even semi-independent living. These are the different, I guess, tacks and themes that we are going to be looking to build towards as part of our housing strategy. And it would be hyper individualized in terms of the placement of that individual based on their specific needs.
Okay, thank you. Kimberly asks, I would like to join the FAC, but was told only one family member, I think only one family member per FAC member, or one family member per resident can be on it. My daughter's father is currently on the FAC. Is there a wait list? There's no formal wait list, but what I would say, Kimberly, is yeah, it is a rotation, and I'm sure that will get to you once your daughter's father times out, such as it is. But yeah, it is a little. We want to ensure that the Family Advisory Committee is as representative, both regionally and in other ways as possible. So to have 8 people on there and have 2 people who are connected to one supported person is a little lopsided, I'm afraid, but I'm sure that there will be a time where your daughter's father is not on it, and then you can take his place.
There was a term limit though, like, wasn't it?
Yeah.
Like you served for how long?
There's 2 terms of 3 years. Yeah.
So you can serve like a
Right.
maximum of 6 years, is that?
Yeah, exactly. Yeah, a
Okay.
number of us are timing out right as we speak. Including
Okay.
me.
Okay,
Yeah,
thanks for
yeah.
that.
Yeah, that's how it works. We have a question from Bregman. I don't know if that's a first or last name. My brother lives in a home an hour and a half from the rest of his family. He has had health issues in the last few years, and his local hospital had to transfer him each time to another hospital. His family would like to have him closer to the GTA. Is there a way to start the process to moving him closer to family? I know that's a complex question, and I'll throw it over to Osmond.
Thank you, Lise. So in terms of vacancies, we do have a very limited stock of homes, and Kerry's Place very rarely experiences vacancies. However, in the event a vacancy does arise or any new spots as part of our housing strategy would open up, we would always consider internal individuals prior to expanding to external individuals. So we would always consider if there's an individual that perhaps, like you've mentioned here, their current living situation perhaps isn't conducive to their health needs or physical needs. We would consider those individuals. So in terms of what you can do as a family member, I would urge you to reach out to the manager and flag that as a request so that we could document that that's a request. And in the event that it does occur, it could be considered. I cannot promise, just because again, each vacancy is going to be different and unique, but I can commit to at least having a conversation around any potential that may or may not arise.
All right. We have another question from Rebecca about the whole CRP test issue. I think this is something that's very specific about whether it's an appropriate test for, I think it's your son. I don't think anybody has said that the CRP test is not worth considering. I think he said it just may be not the most appropriate, depending on the circumstance. So I think if you have a question, if you want the CRP test, I can't imagine that it would not happen for you. I don't know, Carm, Jennifer, or Osman, whether you want to add to that.
Yeah, as mentioned before, if this was a test that the substitute decision maker wanted to ask the physician about, yeah, we wouldn't be in a position to say no if that was something that was asked for. Yeah.
Yeah. Any other questions about anything else? That's the end of our chat questions. This is a time you can ask. We promised you could ask. We've got Kerry's Place, most senior staff here. And so if you have any questions about anything else, this is your time. We really appreciate you've been able to join us. So this is what you get for that. You get expertise all in one place. So please ask away.
Say, Lise, this is Sue. I'm not going to ask a question, but I just would like to make a comment. You know, we've been talking about we gave examples of the 3 homes that we've been able to specifically make the Harmony home. We have 10 individuals there who are medically complex, and we have the other home, the Park home, is also going to be changed into a home that is appropriate for people with disabilities and medical problems. I can't stress enough how much this costs. And the money does not come from the ministry totally. We have another organization called Kerry's Place Residential Services, and they own a number of our homes. And they are a separate organization, and they help fund these homes. For example, Le Parc is costing us about 2.3 million, I believe. And so they are very much involved in providing the funding. The ministry does not provide any capital for these homes. They will provide some repairs and maintenance for homes. We have well over $2 million a year in repairs and maintenance that are required by our homes. So we are continually strapped for cash because we don't get funded for the repairs and maintenance. So I'm going to put a plug in here because you saw that we have this very I would say great housing strategy goal that by the year 2031, we want to be able to house another 68 individuals. It means that we're going to have to find homes. We're going to have to build homes. We estimate that the cost is going to be close to $35–40 million. We're going to be starting a major fundraising campaign in order to help make this happen. Because again, we don't get funding from the ministry for any capital. So I just wanted to put that plug in because we hope that the families are going to, as they see our funding campaign coming forward in the next few years, that it's going to help us expand so we can serve more individuals, but it does come at a price. So I wanted to put that plug in. Thank you, Lise.
Oh, you're welcome, Sue. All the more reason why people should talk to their MPPs. Try and establish a relationship with your MPPs, especially if they're cabinet ministers. There are a lot of cabinet ministers in the GTA where a lot of you folks live. If one of them happens to be your MPP, try and establish a connection and talk to them about how important Kerry's Place is. Carm has posted, first of all, I have a question. Who can I contact regarding community programs and other services for my 18-year-old? Thank you so much for all this information. That's from Haggett. I think, is that you, Carm? Or would it be Kelly?
I put intake at Kerry's Place, and that way, yeah, all the information's there, and we have some really great information on our website as well.
Yeah.
Yeah,
Thank you for that.
you're welcome.
If there are no other questions, because Sue has raised an important point, we are always looking for topics for town halls. And I've always thought a good topic would be about how families can get involved in sort of advocacy. But if anybody has other thoughts of what they'd like to hear about in a town hall, please raise them now, either in the chat or when you get the email. You're going to be emailed a survey for your thoughts about this town hall. Please let us know if you have thoughts about other topics that you'd like to hear. If anyone has a good one right now and you want to yell it out, please do so.
Hi, it's Maria. Can you hear me?
Yes, Maria, go ahead.
Hi.
We see your
I'm
hand.
sorry, I haven't been able to find the chat box.
That's fine.
in order
That's
to
fine.
ask the questions. I'm to get back to Sue last comment. I'm just curious, and I'm just throwing that in, hoping to maybe ask information on this. My son is my only son. There are no other siblings. So when I pass, I believe I've asked this in the past, but I don't recall that I had an answer on this. I don't know if I could leave the house in trust, let's say, to ensure that my son could reside in it should there be issues with government planning. Let's say the government decides, like crazy USA is doing lately, so many changes, and there's no home for these boys out of circumstances. Can anything be done to ensure that, let's say, if I have a property, but he can't live in it, given that he needs to reside in it for me to live it for him? How do you go around this?
Well, Maria, it's a good question. It's probably not one that can be answered right now, but you raise a really good point, because we did handle some of these questions about estate planning
And
a year ago
it.
in our town hall. And I think we might want to run that town hall again about finances, estate planning, guardianship, all those issues. Because A, the law keeps changing, and B, not everyone attended last year's town hall on that
I
one.
didn't. I don't know why, but anyway, I know I didn't. So
Right.
I'm on an important topic.
It is really important, and we ran out of time. It was a complex town hall, so I think that would be a good one again. But in the meantime, if anybody, I just don't think, I think it's too long an answer for you right here tonight.
Right.
But yeah, if you could probably talk to Osmond directly, but I think that in the meantime, we should probably plan a town hall on those issues again.
Okay, thank you.
With a lawyer. And if you know a lawyer friend or have a lawyer handling any of this, it'd be a good time to bring it up with them as well.
Yeah.
But in the meantime, Lise, I'm just saying, Maria, you could contact me, Sue.Coke, and at Kerry's Place, and I can put you in connection with our director of fundraising, because you might be able to get some more immediate answers. We can help you out there, I think.
Okay, I'd appreciate that. So I contact you, in other words, for.
Yeah, just contact me. I just need your email so I can get back to you.
Okay, thanks very much. I will.
We have a few people also saying that they'd like to see another town hall on finance and estate planning. The one we did a year ago is posted on the Kerry's Place website. But I think that we learned a lot from that town hall, and I think it's time to, we ran out of time on Henson trusts last year. We didn't go into a whole, we didn't do as much as we should have possibly. And I think Sandra is noting that we could probably spend a whole hour on Henson Trust. That's probably true. And the whole issue of guardianship, which I personally am still in the throes of getting. And I'm telling you, I could do 1 hour myself on getting guardianship. So it's not easy. That's one headline. Yeah, I think there's a lot of interest in those issues. There's a question that's unrelated to these kinds of legal issues. We'd like to raise the question of personal care workers being moved out of the home without having an opportunity for discussion. I don't know, Francis, you asked that. Maybe you want to elaborate on what you mean by that? Are you talking about?
Yes, okay, so it's Diane talking right now. Francis is right here next to me, but recently Francis's husband passed away, which is Kathy's dad. Kathy is in the home in Thomasville. And I guess there was something going on in the home, and her personal care worker that's been with her forever was moved to another home. And it was a lot. It was a lot of change for Kathy at that time. And I think it's still a lot for her right now today to all the changes that are going through. And she's not able to come home right now because there's a move and the house is up for sale. And so, yeah, so we're just wondering how it was unfortunate that it all happened the way it did. And so we'd like to be made aware of why that would happen.
Mhm.
Our grandmas.
Yeah, I can respond to that. Thank you, Elise. Thank you so much for the question, Francis, there. I'm going to ask, because this is a very specific issue, if you could send me an email and I'll have a discussion with yourself along with the director and the manager, just because I feel that they would be in a better position to be able to share some of that information with you. So if you could reach out to me, my email is in the chat, but I can reshare it with you directly right now and we can set something up to talk.
Okay, that's appreciated. Thank you.
I guess in general, though, Osmond, I guess the goal is generally to inform families when there's a staffing change, right? Like
Absolutely,
that?
absolutely,
Yeah.
absolutely.
Yeah.
Okay.
I think it's
Thank
probably fair to say it doesn't always happen, but I think the goal is always to try to ensure it happens.
No, yeah, I think we were made aware of the staffing change after the decision was made. However, it's not a decision we were on board with.
They took her out of
Yeah, they took
and
her
sent her to
to another home, to
Tweed.
another
Sent her to
residence. Yeah. Okay, so we will reach out. Thank you for that.
Yeah, I ran
Okay.
into that same problem. My son had been very comfortable with his liaison for years. And I was informed that she was moving to actually help start up the Harmony home, the new home that Osmond has mentioned. And I did everything in my power to plead with the powers of be, the staff. Isabel, I can see you smiling. I don't know whether it's like, does the parent really have a say in who cares for their child? I felt I wasn't listened to. And my son lost his friend who knew him so well. And it was like a death in the family. There have been changeover to staff. It's like there's always new staff coming, staff leaving, managers changing, new manager assigned 6 months ago. He never phoned me to say, hi, Linda, I'm the new manager of your son's group home. Do you want to have a chat? Never. I know his name. I've contacted him. It's just, we talk about the personal centered planning. Does my son have a choice as to who cares for him? Does he have a choice? I don't really think he does. I see so many important staff personnel being shuffled that it breaks my heart. These are autistic adults who need consistency. I'm frustrated. That's my story. And I really didn't feel I was listened to. And my son, who is learning to express himself, learning to express his fears, learning to express what he wants, wasn't involved in the decision to move his main person. Recently, there's been another person moved, another staff person that has been crucial to my son's home, moved out to a different place, to a different home.
But if I could, I don't mean to interrupt you, but just for time, I think I hear your frustration, Linda. I'm wondering if we can ask Osmond about the process here of what happens when staff is moved and what's taken. What are the factors that are considered when staff are shuffled? I think many of us here have probably gone through a version of what Linda's talking about.
Well, it just seems that a lot of shuffling seems to take place, even in the manager role.
Right.
And like, I really don't know how much time the manager of my son's home actually spends at the home with the clients. Like,
Maybe
I have no idea.
Linda, if I could just interrupt, why don't we maybe let Osmond take a stab at it?
Sure.
No, thank you. Thank you for the question, Linda. I do appreciate
I
the
don't think it's a question. I think it's just a frustration that I feel that I wasn't listened to. My son wasn't really given a choice. It was decided for him. Anyways, I'm sorry.
Don't be sorry.
It's a tough one. And don't be sorry. I think a lot of us have felt frustrations that are similar at different times. Maybe Osmond, go ahead and maybe.
I can, and I will reach out to you, Linda, individually, if I may, just to hear a little bit more about your specific situation. But just operationally, there's a variety of reasons why a staff may or may not be required to be transferred. Some of them are self-directed by the staff themselves, and some of them are due to a variety of different reasons. In terms of the management team, I do recall you did make mention of a change that occurred about 6 months ago. I took over this position about 1.5 years ago and immediately began working on a bit of a restructure to enhance our teams and to grow our managerial team to support with some of the concerns that you just mentioned around being able to provide more on-site support, being able to increase their site presence. So we did make some significant changes where we did implement or introduce newer managers to the team and grow the teams in all of the different regions, which may have led to some of the changes that you're seeing in terms of the oversight or the change in oversight for the home in which your son resides. However, those decisions were made in mind to address some of the concerns forward, which include, again, increasing site presence where possible. In terms of the specific situation that your family did endure, I will reach out to you and we will have a conversation around that, because it is our expectation that these changes are communicated to the family and that the family is provided an opportunity to express their concerns.
I was definitely given the opportunity to express myself. It's just I really didn't feel listened to. I really didn't feel listened to. And my son wasn't given a choice.
Yeah, I
but
guess
he's managing. But now that like he's had a new liaison now. With time flies, I would say probably 1.5 years. Now they've switched him to a new liaison. So here he's dealing with another change. Plus he's lost another staff person that's been on site for a long time. Anyways, I won't talk anymore. I'm sorry.
It's okay, Linda.
Can I add something here?
Absolutely.
My sister is 65. She's been there since she was 14. She used to have liaisons that worked with her for years and years and years. And then things started to change, I think, in the workplace as much as anything, that there's a bigger turnover in staff now than there used to be. And she started to have new people assigned to her as her liaison. And at first, it was really difficult for her because same thing, she likes consistency, she liked knowing the same people. But we have found over the years that this change it's always handled really well by the staff at Kerry's Place for a start. And also this has made her more resilient. Now you can change her liaison and she doesn't even tell us. We don't even know about it because it's just nothing for her anymore. She enjoys the change now, which is a total turnaround from where she used to be when she was younger. And like I said, it's made her more resilient. She's more adaptable. So we were really resistant to her getting new liaisons all the time. But, as the years go by, we've come to realize that it is a good thing for her. So that's just my 2 cents worth. We've been where you are, Ms. McNamara, and it really does. You can trust Kerry's Place. They do things right. They really do. And they do care about their people. So there you go.
Thanks, Sandra. That's a nice note. We are over time. If there is not a pressing question about the topic, we did promise this wide-ranging Q&A, and that's great. But we're over time. Are there any questions that were very specific to about aging, medical stuff, housing? You all know how to reach Osman. His email's been posted up here, and Sue, sue.coke@kerrysplace.org. And you've got the email of the rest of the staff who've spoken tonight as well. So I think, Aram's email is up there. If anybody has any other questions, this would be the time. But if not, I really thank you all for taking part in this. These are learning experiences, all these town halls, and every time we do one, we hopefully get a little bit better. There is an interesting idea for another town hall about involving retired pensioners to support residents. That's a Rebecca question. I don't know if that's for a town hall, but it's an interesting question. Sue, is there in this last minute, is there any way to have pensioners volunteer? Any room for volunteers at Kerry's Place to support residents?
Well, I think it would depend on what the need was in the particular house. Some of our individuals need specialized care, and the staff need to have some of that knowledge. So I think the answer to that would be, we do have young adult program and adult programs that are more group. They're more group centered. So there are other things that we do at Kerry's Place for the community individuals. And certainly we can look if people have some ideas of how we can have more volunteers. Absolutely. We're interested.
Well, maybe we can plug that in, this idea of where to use volunteers and how to connect volunteers.
Yeah. I think we would like to look at that more. And just in general, I'm really conscious of the staff turnover and how difficult it's been for the parents and the SDMs and the families. I can't tell you how difficult COVID and those 3-4 years were. And we had so much staff turnover, manager turnover. It was an absolute nightmare. So I hear you. And we're still being stabilizing. after 5 years post-COVID. We're still stabilizing. I can say that our workforce is far, far more stable than it was 3 years ago, but it took a terrific toll on all of us and on the families and on the individuals. So it's not an excuse, but it is a major factor in staff turnover that we've experienced over the past 5 years, basically.
Mhm. All right, folks, I think we'll call it an end. You guys have been very, very patient and liked all your questions. On a final note, if you have any other comments about this town hall or suggestions, complaints, anything you want, and you want to throw them toward the Family Advisory Committee, I've just put up our email, fac@kerrysplace.org. And we can stick handle who would be best to respond to you. And thank you. Jennifer says thank you. We all thank you so much for taking part. I want to personally thank again Diane and Phyllis, our committee folks, and Carm, Jennifer, Aram, Osmond for enormous amounts of time putting this together. So thank you. And good night, everyone. Take the rest of the day off. All right. Bye-bye.
Take care, everyone.
Okay, bye-bye.